pharmaceutical industry globally. Homeopathic physicians, actually all natural physicians, are the nature's assistants. We educate people about how nature heals and how we can assist. Natural laws is absolute. We follow the primary healing principles, the fundamental knowledge through science, right system of medicine, and concept of cure to assess the human body's healing process. Nature heals, we assist, so we teach the art of healing to the sick to heal themselves naturally. Even though my modality and view might completely be different than yours, but our Hippocratic and medical oath and goal to help healing people and saving lives always remain the same. Thank you so much, everyone, for this great opportunity to be part of you, and looking forward to working with you. So I would start to introduce myself again. Dr. Zarrin, the founder of Bioquantum Academy, Homeopathy Nutrition Clinic, and Integrative Medicine and Nutrition in Canada. So for some of you might want to know my credentials or my education, I have a brief kind of highlights here. I have degree in nutritional sciences. I have diploma in classical homeopathic medicine and sciences in Canada. I have PhD in integrative medicine and awarded an Order of Excellence for intensive homeopathic research on obesity for my doctorate degree in Canada. I have several certificate of achievement in homeopathic medicine from Germany. I have certificates in homotoxicology, homeopathic organotherapy, no-thoughts immunization, chemotherapy, and oligotherapy in Canada. I have honored diploma in medical statics in Canada. I'm the author of a quantum anti-aging book, been practicing mentoring, educating, and lecturing in Canada and internationally for the past 2 years. And also I'm the partner, co-chairperson, and a speaker at the Global Scientific Guild. So let me just stop, sorry about that. Okay, I would like to just talk about my general view about the topic, hysterectomy. So hysterectomy is, from my point of view, is a removal of the female identity. My talk is about sharing my holistic view, medical philosophy, natural healing principles, my modality and scope of practice, information and research on the topic of hormones after hysterectomy, for educational purposes only. Hysterectomy, removing the female organs instead of removing the internal disease by the allopathic invasive model, is unscientific and inhuman. It is the action against the nature of human constitution, removing the female God-given identity, causing early and artificial menopause with many aftermath complications, disturbing the female endocrine homeostasis and balance state, causing the female internal disharmony and chaos for life. This is ultimate distraction instead of removing the disease. Hysterectomy causing injury, damaged tissues, shock, trauma, and grief. Causing injury damage to surrounding areas like bladder, urethra, blood vessels, and nerves, and scar tissues for a long time. Causing shock and trauma at all levels of physical, endocrine, hormonal, nervous system, mental, and emotional for a long time. And also infection, possible blood clots in the legs and lungs, and possible side effects related to anesthesia. Hysterectomy causing long-term grief in female because it's the most painful loss for a female. The entire body goes through grief process over the loss of reproductive organ as if losing a loved one. Artificial menopause and aftermath complications such as unnatural hot flashes, mood swings, anxiety, depression, osteoporosis, water retention, weight gain, and low quality of life at all dimensions can be caused after hysterectomy. Allopathic model is not healthcare. Unfortunately, the dominant allopathic model has no solutions to remove the disease in the human body, but has the power and authority to remove the human organs instead. This is flawed science, ignorance, and scientific measure. It's called healthcare. To me, is not. To me, is a butcher shop. No matter how advanced the medical technology is going fast forward, invasive procedure of removal of the human female organs is an ultimate distraction, unscientific and inhuman. Because we can confidently remove the disease on time by correct diagnosis and right system of medicine. So I would like to talk about estrogen progesterone ratio. These are the two main female hormones. No matter in childhood, puberty, adolescence, childbearing, pregnancy, lactation, premenopause, menopausal or postmenopause, or even after hysterectomy, a female must sustain a normal hormones ratio throughout her life according to her state and body needs. Female body should not go through progesterone domination or estrogen domination. In healthy women, progesterone estrogen ratio should be between 100 and 500. If it's higher than that, it may indicate progesterone domination. And if it's lower, then estrogen domination is more likely. Excess estrogen can increase the risk of breast cancer and reproductive system cancer, while progesterone does have an anti-cancer effect. It also provides benefits to all cells in the body, including the brain, heart, nerves, skin, and bones. In all above cases, such as childhood, puberty, before menopause, after menopause, progesterone and estrogen must be sustained in natural ratio, but different amounts for hormonal balance and harmony at all times. Estrogen is produced majorly by ovaries, female ovaries, also by adrenal glands and fat cells. Estrogen are a group of hormones that play an important role in the normal female reproductive system development and secondary female characteristics. The women's ovaries make most estrogen hormones, although the adrenal glands and fat cells also make a small amount of the hormones. The reason I brought it up because all my research and all my treatment based on this. Estrogen helps make women to have the curvier than men by making their pelvis and hips wider and also growth of breast. Estrogen is part of menstrual cycle, helps getting pregnant, and plays a role in developing bones and growing hair. It also helps regulate mood and impact brain development and structure for irregular and absent periods. So estrogen has impact on bone growth, hair growth, and brain growth. That's why at any stage of life, estrogen and progesterone has to be in a right ratio and right amount. How much the female body needs female hormones? Only the female nature, wisdom, endowed intelligence, and a state of health would decide. No doctors can decide that individual female, how much an individual female needs these hormones. We can never measure the right amount of progesterone and estrogen for an individual, no matter before hysterectomy or after hysterectomy or at any stage of life. This is the wisdom of the body to decide. Progesterone also produced majorly by ovaries, by placenta, corpus luteum, and adrenal glands. I mentioned both in estrogen, progesterone, that they are produced by ovaries and adrenal glands. Progesterone regulates the condition of the inner lining, endometrium, of the uterus, produced by the ovaries, placenta, corpus luteum, and adrenal glands. Plays a role in many body functions, such as prepare uterus for the implantation of a fertilized egg and maintain pregnancy. And also regulates body blood pressure, improve mood, and sleep. Progesterone is commonly produced by the ovaries, as I mentioned, and adrenal cortex. And I already mentioned that also corpus luteum, but after hysterectomy, there is no such a thing. These pathways have been destroyed, and but progesterone somehow and some way has to be produced inside the body. So I would explain it later. The most noticeable manifestation of low progesterone levels is irregular period and short cycles when their pathway still exists. But sometimes symptoms like premenstrual spotting may appear. Other symptoms may include mood changes, sleep disturbances, anxiety, and depression. So as far as I explained that when these two hormones, female hormones, are disturbed, production of these two female hormones disturbed, can affect on so many different levels: physical, mental, emotional, and energy level. Progesterone affects the regulation of fluid levels in the body. It's important after hysterectomy. The absence or lack of progesterone can cause long-term water retention and irregular blood pressure. So these are some slides that I show normally. I teach them my course. Now tonight is just a sample course, so I'm not going to go through all the slides to talk about biochemical aspects of the estrogen and progesterone, but I would like to get into the female pathways. So the main female pathways is hypothalamus, pituitary, and ovary pathways. So we call it HPG pathway, which is main female hormonal pathway. As we know, all of us know, and we can see it on the slides, that ovaries cannot produce estrogen and progesterone at any time if hypothalamus is not going to send the releasing hormone to pituitary, anterior pituitary gland, and pituitary gland is not making luteinizing hormone LH or follicle stimulating hormone FSH. There is no such a thing that ovaries can make estrogen, progesterone. This pathway, it has to be intact and always has to be active in order to go through this normal process of hormonal production. So hypothalamus in the brain has two major hormones, one inhibiting and one releasing gonadotrophic releasing hormones. These hormones are going to stimulate anterior pituitary gland, and anterior pituitary gland stimulating, as I said, FSH and LH, and FSH and LH is stimulating ovaries, and ovaries is going to produce these two main estrogen and progesterone. But what happened after hysterectomy? So this pathway is destroyed. There is no HPG pathway anymore. And then what's going to happen to the female body when there is no such a pathway left? So there is the complete pathway, as we see, the hypothalamus, anterior pituitary gland, ovaries, and uterus. So as the reason I show this slide, because there are total hysterectomy and there are partial hysterectomy. So total hysterectomy, the whole pathways, hypothalamus, pituitary, ovaries, and uterus completely destroyed after hysterectomy. But in partial hysterectomy, for example, removing only uterus, initially, when the ovaries already left, they kept the ovaries. Initially, estrogen progesterone production by ovaries would stop due to the giant shock and trauma to the reproductive system as a whole, and also a great confusion to the main female pathway. Gradually, when the body comes out of shock, trauma, and grief, then would start producing hormones, but with totally disturbed estrogen progesterone ratio and amount. It will never get back to normal, this pathway. It will never become normal again, either progesterone dominance or estrogen dominance, until the body, the female body, intelligently switch to another pathway. I would explain the survival pathway that nature endowed in female body for survival. Nature has a backup pathway. No matter the removal of female organs, destroyed main female pathways, and disturbed hormonal connections after hysterectomy, the female constitution does not change and remains female. Nature has intelligently endowed natural backup or survival pathways in the human body, as has done a great job in female. No matter the natural menopause or forced and artificial menopause, such as after hysterectomy, female needs the two hormones, estrogen, progesterone, with right ratio and balanced amount during different stages of life for the rest of her life. Human body has wisdom and always tries to fix itself and find a way to survive when it well supported and directed. So I would like to talk about the nature's backup, and it's a new hormonal pathway in female. In the domain of homeopathy, we do not give artificial hormone replacement therapy or treatment. Instead, we encourage, support, activate the other female hormonal pathways to take charge and bring normalcy and harmony to the female. We do it by assessing and evaluating the state of female body at all levels of physical, mental, emotional, and energy as a whole unit, not just focusing on parts and organs. By choosing the correct homeopathic remedies to stimulate the female body holistically at all levels in order to bring internal harmony, homeostasis, alignment, and balance into the body. By doing so, the essential hormones such as progesterone and estrogen can be made by another pathway according to the female needs and requirements for optimum biological function. So we must switch the female body after hysterectomy to a new pathway. What is another backup pathway by nature? The pathway HPG, the normal female pathway, is destroyed by hysterectomy, no matter partial or total. But the body intelligently can switch over to HPA pathway, which is hypothalamus, anterior pituitary gland, and adrenal cortex. As I mentioned earlier in the two slides of estrogen, progesterone, these two hormones are majorly produced by ovaries, but when there is no ovaries, the body can switch over to adrenal cortex. But how does it work? So we call it HPA axis or HPG axis. So shifting from HPG, hypothalamus, pituitary gland, and gonads, to HPA, hypothalamus, pituitary, and adrenal pathways. If you can see the slides on my right, it's just they're very similar to the female pathways and the way that can produce from female hormones. Natural hormones, estrogen, progesterone production by shifting from hypothalamus, pituitary, ovaries to hypothalamus, pituitary, adrenal cortex. How much hormone is needed after hysterectomy by this pathway? Ratio does not change. Ratio of estrogen, progesterone does not change because female's constitution never changes. It always remains female. But the body decides the amount for the female state. The state of health, according to the holistic, mental, emotional, physical, and energy level, then the body itself decide. As long as we can shift the body towards HPA pathway, then the wisdom will decide how much it needs for the state. Due to no ovulation, no menstruation, no pregnancy, no developing female characteristic, adrenal cortex can intelligently take charge of adequate production of female hormones to bring normalcy to the body. So HPA pathway is hypothalamus, pituitary, adrenal axis. Adrenal is very crucial. Health of adrenal is very crucial and important in this after hysterectomy in female, and especially for people who are like me as a homeopath treating the female after hysterectomy to bring normalcy from HPG to HPA. So the adrenal glands health is very, very crucial. Your adrenal glands are controlled by your pituitary gland, another part of your endocrine system. Pituitary gland, hypothalamus, adrenal glands, they have to be in optimum health in order to make the shift correctly and safely. The pituitary gland is the main controller of your endocrine system. Abnormal signals can disrupt the amount of hormones that your pituitary gland tells your adrenal glands to produce. A major component of homeostatic response is the hypothalamic pituitary adrenal axis, an intricate yet robust neuroendocrine mechanism that mediates the effects of a stressor by regulating numerous physiological processes such as metabolism, immune responses, and the autonomic nervous system. This pathway must function optimally to allow the female body comes back to harmony. Health of hypothalamus pituitary adrenal is crucial to sustain female health after hysterectomy. Adrenal glands produce hormones in response to signals from pituitary gland in the brain, which reacts to signaling from the hypothalamus, as I explained earlier. This referred to as the hypothalamic pituitary adrenal axis. For the adrenal, so as we know, hypothalamus, the same pathway, hypothalamus pituitary adrenal, the hormones such as CRH, the releasing hormone, and ACTH. These are the balance ratio and amount of CRH and ACTH needed for harmony, not to dominate the hormonal pathway HPA. So for example, cortisol that is produced by adrenal glands, if it's not in a normal ratio, can dominate the, or can even block productions of progesterone and estrogen by adrenal glands. And everything has to come into control. So my job doing this is a very delicate job after hysterectomy. I have done several, and the result was fabulous. It was delicate, it's like a teamwork with a patient and the practitioner, but the result is amazing. Adrenal disorders, that's why health of adrenal is very, very important when we shift to HPA pathway. Adrenal disorders and abnormal signals we should not allow adrenal gets wrong and abnormal signals from pituitary gland, because it disturbs the amount of hormones that your pituitary gland tells your adrenal glands to produce. So adequate estrogen and progesterone with the proper ratio and amount after hysterectomy by adrenal glands is directly signaled by pituitary gland. So pituitary gland has to be in optimum health in order to have the right signal, to send the right signal. Controlling the production of testosterone, not to dominate or even block the female hormones production by adrenal glands. As we know, adrenal glands produce androgen testosterone as well. So if testosterone and androgen is dominating the other hormones such as progesterone and estrogen, the female is going to be in trouble. So we have to bring absolute harmony in the pathway of hypothalamus, pituitary, and adrenal in order to have adequate amount of progesterone and estrogen by adrenal glands. The ratio never is going to change because female constitution stay female. So controlling the cortisol, CRH, ACTH production, not to dominate or also block estrogen progesterone productions. This pathway, the HPA pathway after hysterectomy, is not just a life support or temporary state, but is a permanent pathway after hysterectomy for life through the female life. So the second pathway that I work on, it's immune system, endocrine system pathway, because there is a strong and close affinity between estrogen, progesterone, testosterone, and immune system. So this pathway is a major pathway for hormonal balance that I work on after the first pathway. And the third pathway is the endocrine nervous system, immune system pathway. So there is interactions between these major three systems for female homeostasis. So I work hard on this pathway along with the other two pathways in order to bring homeostasis and harmony into female body after the shock, injury, trauma, grief that the body goes through. So my holistic approach is to definitely bring the internal homeostasis and harmony into the female body. As I mentioned on the previous slide, endocrine system, nervous system, and immune system has a strong and close affinity. They work together. We don't work on just parts. We work holistically. These three major systems have to come into harmony, because nervous system is in charge. Hypothalamus, it's all the emotions are created there. So it's part of the central nervous system. Central nervous system definitely has to come into harmony, not affect too much of unnecessary stresses, affects the adrenal glands, produce too much of cortisol, and cortisol is going to dominate estrogen, progesterone. So that has to be under control very precisely, delicately, and efficiently. It's a very, very hard job for homeopath to do so, but the result is very rewarding. The female hormones, when it's kind of disturbed after hysterectomy, as we know, all the endocrine system are connected, especially those three systems that I mentioned. But when there is this disturbance in amount of estrogen and progesterone ratio within it, it affects insulin, it affects thyroxine, it affects cortisol. These all hormones working together. So the chaos at the all the female endocrine system, all the female pathways and hormonal connection, such as thyroid, adrenal, and pancreas, can happen. So we have to bring balance ratio between thyroxine, cortisol, insulin, testosterone, ACTH, all the hormones, endocrine hormones, and so that to bring the body out of disturbed homeostasis and bring ultimate internal harmony. One thing that I always highly recommend to female who come to me after hysterectomy, not necessarily they come right after hysterectomy to me. I have patients that they came after years of they have done hysterectomy, but does not matter. The shock, the grief, the trauma, everything is trapped in female system. There is no such a thing that physically they may get back to normal, but entirely as holistic, as a unit, they never go back to normal unless they go through the right treatment to bring them back into harmony. One thing that I highly recommend to those people that never go on drastic weight loss after hysterectomy, because adipose tissue and fat cells produces some female hormones. So increasing the adipose tissue can be survivable after hysterectomy. For a short period of time, I would ask maybe for 9 months, never go through a drastic and shocking weight loss immediately after hysterectomy, and let the body wisdom work, does its job, and then after we get we shift the body, female body, towards the new pathway, then we can do a healthy weight loss. My integrated approach for aftermath of hysterectomy is definitely we cannot bring the female organs back, but we can bring normalcy, homeostasis, harmony, and balance back, because we cannot artificially create hypothalamus, pituitary, ovary, uterus hormonal pathways, because it no longer exists. We should not artificially supplement the body by synthetic hormone replacement therapy due to high-risk production of cancerous cells. Progesterone must remain in right and balanced natural ratio and measure with estrogen at all times if it's given as supplementations. In the domain of homeopathic medicine, the prominent female remedies and constitutional remedies would remain the same for the female, no matter having reproductive system or without it. Female constitution is programmed and protected by nature and never be changed by hysterectomy. So now I'm getting into my treatment. So I work with a big range of homeopathic medicine coming from Germany and Belgium. I have been doing it for over 20 years. And if some of you know me, that I have a very successful practice. And hysterectomy, even before hysterectomy, during and after hysterectomy, I had several patients that I treated with homeopathic medicine. The very first thing I do, like for example, I had a patient came and said she did hysterectomy like about a decade ago, like 10 years ago. And when I took her case, she tried to just skip it. I said, why'd you try to skip it? She said, that was just about 10 years ago. I said, I need everything from even your childhood. Don't try to just skip it or hide it or not to mention it. These are very important. And I explained that to her. I said, the injury, damaged tissues, it might heal, but not profoundly, not because your body is always going to stay in shock and grief and trauma. So the very first thing I do is to do the same thing, no matter it's 10 years ago, 15 years ago, or 5 days ago. I do the tissue healing. So with I can do it with single remedies such as arnica, hemamelis, belladonna, calendula, rostox, ruta, symphytum, or I have different kind of plexes or complexes in a homeopathic form. I give them a lot of different tissue salts. I give them a lot of according to the case, give them gemotherapy and oligotherapy. I work with 2 major family. One is homeopathic medicine, one is gemotherapy, organotherapy, and oligotherapy. I have to get the shock and trauma and grief out of the system. Otherwise, that female inside that body is going to grieve for the rest of her lives. This is the emotional healing that I have to do it. I have to do to kind of neutralize the charge of the grief. So no matter how much you talk to the person, no matter how healed the tissue got, no matter that grief is like losing a loved one. You get used to it, but the grief is trapped. You have to get it out of the system. So a lot of wonderful remedies in homeopathy, such as Ignatia amara, Natrum muriaticum, Aurum metallicum, Phosphoricum acidicum, Aconitum, and a lot of different complexes. So today, as I said, is a sample course, but in the course, I would walk you through all the remedies, all the treatments, one at a time, one by one, in order to completely, profoundly understand how my treatment protocol works. So again, for every single protocol, I go with a single homeopathic remedy, complexes, gemotherapy, oligotherapy, and organotherapy. After treating the injury and shock and trauma and grief, then I do the constitutional remedy. Because in the beginning, it's very hard to find a constitutional remedy of the female as a totality. So after hysterectomy, totality of female symptoms after hysterectomy, it might be changed, might be the same. The remedies, but the constitution is remaining the same. She's a female. So a lot of great remedies such as CPL, lachesis, timistifuga, pulsatilla, laconium, cyclamen, platinum. There are a lot of good female remedies for after hysterectomy that it works amazingly as a constitutional remedy. And that's going to be my third protocol to give to that person. Bring the female constitution, including energy body, physical body, mental and emotional into alignment. Constitutional remedy does an amazing job to bring all the levels of energy, physical, mental, and emotional into harmony and alignment, and also maintains homeostasis and internal balancing. So I work a lot with homotoxicology. As I said, the complexes are homotoxicology and organotherapy, gemotherapy, oligotherapy. For female support, the female after hysterectomy needs between 9 months to 12 months of support. Also, I do a lot of cellular detoxification and drainage. I work with one of the best, homotoxicology, and I think you guys might be familiar with it, is UNDA. They're coming from Belgium. They have wonderful complexes, and for the detoxification. After the constitutional, remedies, I switched to detoxification and drainage. So I also give organotherapy, which is a very, very important for a glandular activation for endocrine system, because the pathway that is switched over to new pathway, it needs a lot of support, and a lot of stimulation, a lot of support and activation. For example, pituitary adrenal, we have a glandular homeopathy, HPTP. It does amazing job, and there is another one, adrenal pituitary thymus spleen thyroid, HTHY, and also there is only one pituitary TP. For example, I had one patient after hysterectomy. She said her pituitary gland has a kind of tumor. That explains it, that it was very hard to switch the pathway to bring her to the new pathway HPA, because pituitary would give a wrong signal to adrenal glands and can cause a domination of the other hormones. That's why I had to work on the pituitary gland with TP. And also we have adrenal glandular formulation in a homeopathic form to lowering the cholesterol and also a CTH control. Some of you might be familiar with gemotherapy for cellular drainage, for hormonal support. We have big range of remedies for after hysterectomy, such as rubicitis, such as vaccinomycetitis, Sorbus domestica. It's an amazing gemotherapy for after hysterectomy. I give Tilia tomentosa ficus perica for nervous system kind of support. And after hysterectomy, I had a patient that she was suffering from anemia, very, very like a severe anemia. Vitis vinifera and Tamarex gallica there were two main gemotherapy that I added to her treatment, and the anemia after 3 months completely removed. I do give oligotherapy for the enzymatic pathways activation, for electromagnetic, cellular electromagnetic, and also for healthy metabolism. A lot of good endocrine oligotherapy out there. So, in the course, I walk you through everything that is necessary, but not necessarily everything is for one female. According to the case, the female may need just magnesium copper or zinc copper, or just need gold copper silver. It depends, but definitely oligotherapy is highly needed for enzymatic activation and metabolism. I do a lot of homeopathic tissue salts for a structure, for enzymatic action, for pathway mineralizations. We have a wonderful 12 tissue salts that I give. Again, according to the case, I choose normally 4 tissue salts to give to the patient. In hysterectomy that I had several people, a lot of them, I give them Calcaria florica for a structure, and a lot of such as Natrum muriaticum for water retention after hysterectomy. It depends, but there are 12 tissue salts that they are working wonder. Also, from the beginning to the end of my treatment, I always talk about nutrition. I give every patient, no matter just hysterectomy, I give them the genetic diet according to their blood type. I design it for them, and just switch them over to holistic nutrition and natural food. I give them right and the amount I never decide always, when the hypothalamus pituitary gland is the right state of function, they never, the appetite is completely normal. So, but if there is any problem with appetite, either increased appetite or lower appetite, then I have to work on the pituitary and hypothalamus in order to bring it into balance. But I highly recommend them the food for connective tissue strength, such as collagen elastin, high mineral food, high protein for healing and repair. And also the very first thing I ask them to stay away is the inflammatory foods, such as nightshades, or like eggplants, cucumber, tomatoes, cherries, a lot of different ones, because they are histamine releasing food. And during the treatments, we have to minimize the histamine releasing food to control the inflammatory process, because as I mentioned in one of my slides, the immune system and female hormonal system has a strong affinity, and we don't want any inflammation happens during the treatment. So I would teach them to have right food for balancing homeostasis, such as 80% alkaline food, 20% acidic to maintain the natural pH balance. And also, according to the case, if they need some nutritional supplements, I'm not a big fan of supplements, but if they are necessary, I definitely give them nutritional supplements for 6 weeks to maximum 3 months. But after that, the food is the best thing for human body. So as Dr. Clifford mentioned at the beginning, we are having a postgraduate certification courses. Today it was just a kind of introductory session, but if anyone interested, so Dr. Clifford and I, we are conducting a platform. We are offering an educational platform about different topics. So definitely one of them is going to be the hysterectomy that we have a sample tonight. But it's going to be like 4 hours course, and then you're going to learn a lot of different treatments. If you can add it to your current practice, if you want to completely switch over to these treatments, because it's been very successful, I can tell you. Sorry. Hello. Okay. Dr. Clifford, do you want me to stop sharing or?
Oh, no, I didn't did I do that?
Okay, let me just, okay.
Did I do that?
I'm back. I have tried to come back. I didn't know which button should I press. So yes, this course is going to be, I have already been teaching it in my, hormonal course. Hysterectomy was part of it, or kind of disturbed hormonal is part of it. But now we are going, me and Dr. Clifford, we're going to teach it in depth from 2 different views. I'm sure that you might have different views, but again, in addition to your practice, I think it's gonna do amazing, job if you can add it to your practice. Well, so if you have any questions.
Yeah. Anybody have any questions about so far, how we've done so far? You did pretty well, Dr. Zarrin, only 50 minutes. So
you did very well. Hey,
Thank
Doctor.
you.
How are you? I'm Dr. Halasa here. I have a question.
Halasa, how are you? I haven't seen you for ages.
Yeah, you're right. You're right. So I have a question here because I want to learn about what you mean by alkaline food and acid food. That's something I have a problem with. So I want you to tell us what is your side of the story.
Okay. I think I should stop sharing, right? Okay.
Yeah. Is that okay?
You already did?
Yeah. Mm-hmm.
Okay, perfect. So, okay, Dr. Alasa, okay, thank you so much for your question. So, body has to, body has the different pH in different part of the body, right? Different pH. But the pH of the blood has to be neutral. It has to stay in 7.35 or slightly, less. Otherwise, the body goes to coma and dies. So at this point, human beings, they're having a lot of acidic food, and it disturbs this pH level of the blood, which causes a lot of problems. I treated patients just by correcting the pH level. They didn't need anything, just correcting the new food and to bring the pH into balance. It's very, very, very crucial to understand this. And that's why the body needs more alkaline food, less acidic food in order to sustain the neutral pH at the blood level. So when I say alkaline food such as green leafy vegetables, such as nuts, such as acidic food such as meat, everything meat products, dairy products, legumes, wheat products. These are all acidic. But mineral based food such as green leafy vegetables are more alkaline. So 80% of your food, for example, a lunch, should be alkaline, 20% should be acidic. So it just explains it. You cannot have big portion of meat and just you can, but I mean it's just harming you. So that's why I say 20% acidic, 80% after metabolism and assimilation, it becomes neutral, comes to the pH level, comes to neutral. So I don't know if I explained it.
I just want to clarify that because this is very important topic, and I understand your point, but the reality is that when we eat anything, some doctors think alkaline and acidic food is dipping the pH meter into the food. And if it is alkaline, that is alkaline food. If it's acidic, it is acidic food based on the pH of the food itself. So you're not saying that we are classifying the alkaline acid food based on dipping in the pH meter into the food, and if it's alkaline or acid, we define it that way, right? You're saying that you're eating the green vegetables because it contains polyphenols activates the mitochondria, and when you activate the mitochondria and continue with the electron transport chain, you prevent pyruvic acid accumulations. So alkaline food is actually food that nourish the mitochondria. So we call it mitochondrial nutrition. Anything that activates the mitochondria will drop the acidity or decrease the production of pyruvic acid. If that's the case, yes, I agree with you. Yeah. But if you said to me lemonade is acid, and if you drink it, it will turn your blood pH acidic, that's where I have a problem. And because that's when there is misconception with some doctors in understanding the pH of the food based on pH, they're measuring the pH of the food. So it's like lemonade, it's acidic, and if you drink it, it will turn your blood acidic, and that's not good. So that's not right. And that's what the thing I want to make sure that the audience here understand, that whatever we eat, it will not change your pH because your body will excrete it through the urine. The pH will be stable. If any increase or decrease in pH, it's a disaster. I mean, in other words, you end up with coma and Alzheimer's. So the pH in blood will not change. What will change is eating mitochondrial nutrition. Activating the mitochondria will decrease the pyruvic acid and decrease the lactic acid accumulations, things like that. Yes, you're right. Is that the same lineup? Is the same understanding here?
Yes, I said after assimilation. So Dr. Al-Assad, what I say alkaline food is, I don't mean the food is alkaline. Alkaline food is based on minerals. Minerals are alkaline in the nature. Proteins in any form, protein in any form is acidic. So, but I didn't say that, I mean, turns to acidic. So I don't mean the food is acidic. It turns to acidic, as you said, after assimilation. I said that 2 times in my talk, as assimilation. So that's exactly, I think we are on the same page. So.
Yeah, we're on the same page. Just make sure there is a lot of doctor's perception there. There's, if you go in the internet and you write down acidic food and you write down conspiracy, there is misunderstanding. They think that the alkaline food is like lemonade is acidic, that's alkaline. Milk is acidic, is acidic, is alkaline, in fact, milk. So that's how they think. They think milk is alkaline, lemonade is acidic, based on the pH of the whatever you are eating or drinking, changing the pH of the blood. But now I think we are clear that it's after the assimilation, after the metabolism, and that's true. Exactly. Because the protein will generate uric acid, and you're right. But how you able to turn alkaline food is actually anything that activates the mitochondria and move the whole food into electron transport chain, preventing the accumulation of pyruvic acid and lactic acid. So that's my thing, and I think we agree in here. I just want to clarify that because there is a lot of misunderstanding in this topic.
Exactly, Dr. Alessa, like a lot of misunderstanding about alkaline thing. For example, they recommend.
What? Sabrina told me not to cook tonight.
Like some recommend having alkaline water. It's so dangerous. Anything that comes alkaline, a form of alkaline in the body, is very dangerous because, for example, alkaline water, it's sometimes the pH is above 9 or 10, and comes to a stomach. That a stomach is the most acidic part of the body. It sometimes is 1.5. Imagine alkaline number 9, 10 comes to the acidic part of the body. It can completely destroy the digestive system. So anything that in a form of alkaline coming into body is dangerous. What I'm trying to say is just have to turn to alkaline and acidic. So absolutely. So I think we both are on the same page. So.
Thank you very much. You made my point here. Yes, we agree.
Thank you. Thank you. Let's Dr. Clear for the start. God bless Dr. Clear to get a chance.
Okay, there was a question. Do you have any resources to learn more about alkaline foods?
Resources. I am the resource by myself.
Okay, so we're going to bring. Okay, so
but they can easily find it and everywhere. So, but.
Okay. All right. Well, we'll bring it up as one of our topics. Okay. That's why I like these questions. Okay. That'll be one of our
topics. I have
topics.
a course actually on pH. Dr. Kliefel, I think you.
All right. You and I will work that out. Okay.
Yeah. I think you were on the Global Guild that I had that talk for 1 hour.
So Dr. Mulho, we will present it as at least one whole class.
Yes.
Okay?
Yes.
Yeah,
and that's very necessary. Yeah. Okay.
And then Dr. Smith just had thanking Dr. Halassa for clarification about what was meant by alkaline and acidic foods. So those are the comments in the chat.
Any other questions?
Okay, so now it's my turn.
Go ahead.
So it's now my turn. So I'm going to give you a little bit different perspective. So most of you know that I'm sort of the hormone guy. I'm the hormone king of Reno. I'm called, or the hormone scourge of Reno. So we're going to talk a little bit more of the a little bit more of a traditional medical model, but we're gonna pretty much turn everything on its head. We're gonna sort of bust myths. That's what one of the things that we want to do. I like Dr. Zarrin's approach because it's completely different from what I do, and it gives us an extra leg up especially one of the comments that I get frequently is there anything I can do outside of medical medicine? And so that's part of what we're going to learn here. So I'm going to do the first part of this talk. I gave this talk about a month ago in Florida to the Age Management Medical Group, and it came out of a bunch of questions from my patients. That there seemed to be a raft of them showed up that said that my doctor said, fill in the blank, you don't need progesterone after a hysterectomy, and they said don't use it. And those of you who know a little bit about my background, I was an OBGYN for a short while, and back in the late 70s and early 80s. And back then, we would do what gynecologists would do. We would do hysterectomies, and then we would give our patients Premarin, which was synthetic estrogen. And we would tell them they didn't need progesterone the second half of the cycle because they didn't have a uterus anymore. And I remember when I was a resident commenting to one of the senior residents, because we would have, post-op clinics on Tuesdays and Thursdays. During one of them that says, well, half of these patients are going to come back within, and it wasn't really a half, but a good number of them will come back within a year with breast cancer. And the answer I got was, well, that's just the way things are. Nobody put two and two together. So we're going to bust some of those myths also. So let me see how I advance this. And so again, remember, this was a CME credit. Natural versus synthetic progesterone, the case for not using progesterone, the case for using progesterone, and the effects of progesterone on chronic diseases. We'll save testosterone for another time. So as you heard Dr. Zarrin state, where it's produced, it thickens the uterine lining and making a bed for a fertilized egg. It peaks at day 21. It falls to near zero without fertilization, and the cycle repeats. Premenstrual cycle or PMS symptoms occur when, because estrogen also drops after the day 21 to day 28, and there's a gap in the ratio, as Dr. Zarrin mentioned, between the progesterone and estrogen. When there's too much estrogen versus progesterone, that's where we get the PMS symptoms. Here's a schematic of the cycle, and here you can see it's pretty much flatline. It starts to raise after the corpus luteum, or the ovum is expelled from the corpus luteum. It raises, it peaks at day 21. This is estradiol, and also has a secondary peak right about here. And so this is when we measure our lab values when patient is cycling, this is where we want to get it, usually days 19 through 21. And again, here is our schematic of where our PMS symptoms are the worst. If the symptoms occur after the menstrual cycle starts, it's an estrogen issue. If it starts before the menstrual cycle ends, it's usually a defect in progesterone. So there's just a little tip there on how to tell one from the other. It's the dominant cycle of the second half of the cycle. I like using analogies. It's the political operative cleaning up the candidate's messes. The candidate in this case is estrogen. You know, when a political candidate says something outrageous or silly or offensive, their handlers come running out, to give the to say, no, they didn't say that, they didn't mean that. Let's see, somebody needs to be muted. Marla, okay, got it. The candidates needs to be, we have to make a correction. Progesterone is estrogen's correction. Estrogen wreaks havoc on the body when it is dominant. It causes headaches. It causes cysts, and it causes cysts in the organs that are affected by the uterus, or by the progesterone estrogen ratio, which is mainly the breast, the uterus, and the ovaries. But also, don't forget, gallstones are intimately related to estrogen excess. And frequently, patients will come in and they'll tell me they had their gallbladder out 10 years ago, and now they're having symptoms of, they have ovarian cysts, they have breast tenderness, they have breast cysts, they have breast cancers. They're all interrelated. And in our highly specialized medical world, Each specialty looks at their own little sort of fiefdom of their own little turf, and they don't look at the big picture. And then when somebody like me comes in, that's our job, is to look at the big picture. Okay, estrogen is the cleanup crew. I liken it, if you're old enough to remember the Honeymooners. Remember Ralph Cramden? He was a bus driver. He was, this Jackie Gleason. He was a big fat. He was very boisterous. He was always looking for a get rich quick scheme. It always ended up biting him, in the back. And Alice, his long-suffering wife, was the cleanup crew. So Ralph is estrogen, and Alice's wife is progesterone. So, and then I like again, Bing Crosby had a song, a long time ago, accentuate the positive, eliminate the negative. And the next two lines were latch onto the affirmative. And the last line in the first stanza was don't mess around with Mr. In Between. So for progesterone, the positive is it balances estrogen and improves sleep. It has a naturally calming effect. It lowers blood pressure. It helps the body eliminate fat. It lowers cholesterol. It improves scalp hair. It balances fluids. It increases metabolic rate. It's a natural diuretic, a natural antidepressant, and is an anti-inflammatory. This is, again, Dr. Zarrin showed you a similar chart. This is natural progesterone. These are the synthetics. This is a hormone. This is a drug. And the literature is rife with confusion because they call everything just a progestin or a progestogen. And progesterone is not a progestin. They're completely different, and they act completely differently. Here's the difference between natural and synthetic progestins. Natural progesterone maintains pregnancies, improves sleep, mood. It acts as a diuretic. It does not affect blood sugar. It improves the blood lipid profile. It maintains estrogen dilated blood vessel widening. It does not promote coronary artery disease. It prevents breast stimulation and breast cancer. The synthetics do the opposite. It causes birth defects, causes depression, causes fluid retention. It increases insulin resistance, worsens lipid profiles. It constricts blood vessels. It induces coronary disease, and it increases breast stimulation and causes breast cancer. These are your birth control pills and your synthetic progesterones. Side effects from progestins not seen in natural progesterone are all of these. It increases appetite, weight, fluid retention, irritability, depression, headache. It decreases energy. It causes bloating, breast tenderness, decreases sexual interest, causes acne, hair loss, nausea, insomnia. It interferes with the body's natural progesterone production. It does not help balance estrogen. It remains in the body longer and causes spasm of the coronary arteries. Study done, 722 patients, 33-year follow-up, found that low progesterone had an increased rate of cancer. And there's a belief that it's not the estrogen that is the cancers, it's low progesterone. There's a 10-fold increase in death from all cancers in patients with low progesterone. They had infertility and luteal phase defect, and a 5.5 times incidence of premenstrual breast cancer. The EPIC study, this was done after that WHI study that came out that caused all the kerfuffle and said, estrogens were bad. This was a study done 5 years later with 3 times as many patients. If patients had no hormones at all, that's this line here, the incidence of breast cancer was 10 per 100,000 patient years. Synthetic progesterone, patients had a 20% increase versus baseline of breast cancer incidence. Synthetic progesterone and synthetic progesterone or progestin had a 40% increase in breast cancer incidence versus baseline. And natural estrogen and natural progesterones, believe it or not, had a 10% decrease from baseline. If you gave patients no hormones, they had a 10% decrease in estrogen and progesterone. And so it does not mean that the patients can't get breast cancers from a natural estrogen and natural progesterone, but the incidence, and these are percentages, are less than if we gave them nothing. Our rule of thumb in our clinic is we never, ever, ever prescribe any type of estrogen without a progesterone. And we never, ever, ever prescribe any type of synthetic hormone, period. And we make our patients pinky swear on that. Symptoms just of progesterone deficiency, just so you're up to speed on that, PMS, depression, anxiety, irritability, nervousness, breast tenderness, bloating, water retention, bone loss and osteoporosis, uterine fibroids, excessive menstrual bleeding, decreased good cholesterol, and insomnia. And these last 5 here are actually, if you look at symptoms of excess high estrogen, you'll see the same list. And so our goal here is to get a proper progesterone estrogen ratio. Causes are menopause, stress, high sugar diets, high fat diets, hypothyroidism, deficiencies in minerals, vitamins A, B, B6, and C, zinc, excess prolactin production, excess arginine intake, and certain antidepressants. There's your references for that. In the perimenopausal patient, progesterone is the first hormone to devolve. This is from the I Ching. It perfectly describes progesterone deficiency. Onset of stage 5, her peak condition declines gradually. The Yang Ming channel is depleted, her face withers, and her hair begins to fall out at the age of 35. And that's from the I Ching. Symptoms, again, are agitation, irritability, headaches, short-tempered, insomnia, bone pain, poor libido, emotional lability, weight gain, nervousness, and a decrease in HDL, good cholesterol. The conventional wisdom, and this I got from from the University of Miami and Johns Hopkins University, from the Endocrine Society. This is the conventional wisdom. This is the quote unquote medical doctors approved approach to the midlife crisis, the symptoms of anxiety and depression. SSRIs, that would be in the Prozac, Zoloft class, plus 1 SNRI, which is a difficult medication to get a patient off of, venlafaxine or Effexor. I tell my students if they prescribe venlafaxine or Effexor, they fail. We do not like them at all. And CBT, which is cognitive behavioral therapy. If that doesn't work, we're supposed to refer to a psychiatrist. If that doesn't work, we then maybe look for some comorbidities. If that doesn't work, we add tricyclic antidepressants plus atypical antidepressants. And if that doesn't work, then what we do is we add atypical antipsychotics, including pregabalin and gabapentin. And by the way, when you get down to, I'm going to get rid of that. When we get down to these levels here, we don't take these away. This is the prescribed, medical doctor way to go. We vehemently disagree. Physiological changes are volatile early in the perimenopausal period. Estrogen levels can actually increase by 26% and they rise erratically. Some patients say they feel like they're pregnant and they actually feel pretty good. But the ovulation and progesterone levels become insufficient and absent. And remember, our patients were not created with a fluoxetine or Prozac deficiency. Natural progesterone is physiologically based therapy. It improves sleep. It treats the vasomotor symptoms. It does not increase breast proliferation, it increases bone formation, and has beneficial cardiovascular effects. And there's the reference there. In the postmenopausal period, progesterone prevents the proliferation effects of estrogen on endometrial cells that lead to cancer, and it also increases bone density. The conventional wisdom is that post-hysterectomy patients without a uterus have no need for progesterone. And our goal here, so I like this one over here. Those of you also know that I have a degree in medical acupuncture, and one of our early on teachers said, we're sitting in the classroom, I want you to unzip your brain, turn your head upside down, empty everything out, and then turn yourself back over, and now we're going to start over again. Or over here, Andrew Lloyd Webber, we're going to open up our mind. So post-hysterectomy, the conventional wisdom is you do not need progesterone. This is a medication called Bijuva. It is a bioidentical estrogen progesterone pill that is FDA approved, and it is natural. It is not synthetic. On their package insert, it states that if you do not have a uterus, do not use this medication. You do not need the progesterone. I talked to the company about this, and I believe that the FDA made them put that on there. The Cleveland Clinic, if you no longer have a uterus, you typically do not need to take progesterone. The Mayo Clinic, if you've had your uterus removed, you may not need a progestin, and there you go. It's not progesterone, a progestin. I got this from, I looked for a quote from someone, and I found this. So this is an app called Health Tap. You can sign up on here and answer questions from patients, and sometimes you can get some consults on there. This was a 43-year-old patient. What are the pros and cons of taking progesterone after a total hysterectomy? And Dr. David S., an endocrinologist for 41 years, answered, there are no pros. There is no advantage to taking progesterone after a total hysterectomy. Progesterone secretion induces the onset of a period, which is of no significance after a hysterectomy. Pretty cut and dried. It was a Judge Judy deal. It was a yes or a no. Well, we vehemently disagree, and we will present. I'll present the rebuttal right now. Natural and synthetic forms of progesterone have signal steroid receptors outside of the reproductive tract. There are androgen, glucocorticoid, mineralocorticoid receptors located in other mucosal sites, including the kidneys, the cardiovascular system, respiratory, GI tract, bone, and central nervous system. In the kidney, progesterone will increase diuresis. It activates the renin-angiotensin system, and it blocks aldosterone. It triggers catabolic metabolism. It relaxes smooth muscle. It increases calcium phosphorus excretion. It raises basal body temperature. It is sedative and analgesic. It improves visual memory. It improves proliferation and differentiation of osteoblasts, and it is immunosuppressive. In multiple sclerosis, the administration of estradiol and progesterone protects the brain from demyelination and starts to stimulate remyelination. In the thyroid gland, progesterone increases thyroid levels. Estrogen, on the other hand, increases thyroid binding globulin, which lowers thyroid production. It is immunomodulatory. It decreases NF-kappa beta. And in the bone, it stimulates osteoblast activity, increasing bone density and help preventing osteoporosis. And there are your references right there. Estradiol is carcinogenic in breast cell cultures. Normal breast cells proliferate after estradiol treatment. Breast tissue becomes quiescent when progesterone is added. Estradiol upregulates the cancer-promoting gene BLC-2, and progesterone downregulates it. Progesterone is a neurosteroid. It is manufactured independently in the brain from the periphery, and it is manufactured by astrocytes and oligodendrocytes. The hormones in the brain follow the same steroidogenic pathway as in the periphery, but they are generated independently. They regulate the excitatory inhibitory balance of the neurotransmitters glutamate and GABA. It acts as a microhormone or a fine tuner of the peripheral macrohormones. Sufficient GABA levels are necessary to relieve anxiety, reduce stress, improve sleep, and they're neuroprotective. They stabilize mood disorders. Progesterone maintains adequate GABA levels. Low progesterone, no progesterone, creates a situation with excess glutamate to insufficient GABA, which causes aberrant behaviors. Neurosteroids account for a high degree of pathology associated in traumatic brain injury. Here's our steroidogenic pathway. We've talked about testosterone converting to dihydrotestosterone via 5-alpha reductase. The 5-alpha reductase inhibitors right here are used to prevent this in young men ages 18 to 45. This is used in a low dose called Propecia to block this conversion, which when DHT accumulates in the scalp causes hair loss. It also can cause prostate enlargement. Unfortunately, what was missed or ignored or was known about and tried to be hidden, there's some lawsuits going on at the moment, is that there's another pathway from pregnenolone to progesterone to dihydroprogesterone, similar to testosterone to dihydrotestosterone to allopregnenolone. Allopregnenolone is the hormone which stimulates GABA production, your calming neurotransmitter. Your benzodiazepines stimulate allopregnenolone to produce GABA. So you take Valium, Xanax, and the lorazepams, all of those, clonazepams, they act by stimulating allopregnenolone to make GABA, your calming neurotransmitter. Progesterone does the same thing. When we use 5-alpha reductase inhibitors, about 1% of the time, the patients can end up with severe mental problems, anxieties, depressions, and sometimes they're even permanent. And what was overlooked is that the conversion of progesterone to dihydroprogesterone to allopregnenolone, which stimulates your GABA production, the rate enzyme here is 5-alpha reductase, the same as here. And so we have a whole lecture on post-finasteride syndrome, and perhaps we will, in this seminar, show you that one. This is just a schematic of the same thing. So pregnenolone converts to progesterone, to 5-alpha dihydroprogesterone, to allopregnenolone. This is where your GABA is stimulated. And if we use a 5-alpha reductase inhibitor, we lose our GABA. Decreased progesterone causes decreased allopregnenolone, which causes a decrease in GABA, your calming neurotransmitter. Here are the symptoms of decreased progesterone. Here are the symptoms of decreased GABA. And as you can see, they are the same. This is just a schematic of the same thing. And here are your references for that. Progesterone administered post-TBI inhibits the inflammatory agents that accompany traumatic brain injuries. Progesterone after a traumatic brain injury reduces cerebral edema, necrosis, apoptosis, blood-brain barrier compromise, and inflammatory mediators. It reduces neuronal loss in the central nervous system, and it reduces age-related myelin loss. It attenuates the cytokines interleukin-1b, TNF-alpha, and the cerebral cytokines, which cause cerebral edema and permanent neuronal loss. There is a 50% decrease in mortality when progesterone is administered post-TBI within 48 hours. There was a phase 3 trial, which for whatever reason, the researchers monkeyed with the doses and they used inadequate doses, which of course showed that it was an inadequate trial. The proper dose is 8 milligrams per kilogram for 24 hours intravenously post-TBI. Here are your references for that. Okay, in memory, cognition, and progesterone sufficiency in the postmenopausal years, naturally cycling reproductive years, there's no consistent relationship between progesterone and cognition, and no association between serum and saliva progesterone concentrations in cognitive performance. But in the postmenopausal years, within the first 6 years of postmenopause, progesterone levels are positively associated with improved memory and global cognition. So we need to start it early. And Alzheimer's disease is closely related to abnormal glucose metabolism. Progesterone increases the expression of the GLUT3 and GLUT4 in the cortex of the APP PS1 mice, and accompanied by an improvement in learning and memory. Progesterone also increases the expression of CREB and PPAR gamma pathway. Remember, the PPAR gamma pathway are the TCDs that are used for diabetes. And progesterone significantly improves glucose metabolism of the neurons. Progesterone is neuroprotective, and its effect is due to its positive effects on glucose metabolism. Blood clots are always a hot topic, and when we see no hormone therapy, we have a baseline of relative risk. These are your synthetic estrogens. These are your transdermal natural estrogens, a slight increase. These are your synthetic progesterones here, or progestins, sorry. And this is your naturalized or micronized progesterone. And as you can see, there's again a decrease versus versus you doing nothing, decrease in thromboembolic phenomena. These are the cytokines and CD4, CD1 cells that are positively affected by progesterone. I'm going to just use that as a reference. These are your laboratory studies. And the way we get our positive ratio, if the patient is cycling, we want to get our lab values on days 19 to 21. We get an estrone value, an estradiol value divided by progesterone, and we call that the EP ratio. Patients that are estrogen dominant as a comorbid factor to TBI can cause greater disturbance in neurochemistry, especially with GABA. If patients have an elevation, and this is actually a topic for another day, but if there's an elevated in estrone, if the estrone levels are greater than 100, we will treat the patients with 7-keto DHEA. We start at 25 milligrams at bedtime, it can go up to 100. Usually 25 to 50 milligrams of 7-keto DHEA will decrease estrone levels by about 50% within 4 to 6 weeks. They work quite quickly. And if you'll recall, maybe 10 to 12 years ago, Dr. Oz, a popular daytime TV show, he was touting 7-keto DHEA for weight loss. Well, estrone levels accumulate weight in the midsection. So 7-keto DHEA will lower estrone levels. That's our goal, and we should get some weight loss with that. The estrogen progesterone ratio, we want that to be less than 250. As it gets higher and higher, we get more and more severe symptoms of estrogen dominance: headaches, sleep issues, bloating, mood swings, anxiety, depression, breast tenderness, breast cysts, uterine fibroids, ovarian cysts, endometriosis, and gallstones. Early on, so I've been doing this for over 20 years. Early on, we did not get estrone levels. We got progesterone and estradiol levels. So if you don't have an estrone level, you take your progesterone and level, then now we're going to multiply it by 1,000 to even out the units, divide it by the estradiol, and we'll get a normal ratio is a 100 to 500. Anybody less than 100, you're estrogen dominant. Anything greater than 500, you're progesterone dominant. So you can go by symptoms. Estrogen dominance is breast tenderness, breast cysts, fibrocystic breast disease, uterine fibroids, ovarian cysts, spotting between periods, heavy periods, irregular periods, or progesterone excess, which is bloating, anxiety, and along those lines. Our dosing capsules, you want micronized progesterone. You do not want to use the synthetics to tell if it's the micronized or natural progesterone. The doses, if you go to a regular pharmacy, FDA approved fixed doses are 100 and 200 milligrams at bedtime. There is a under the tongue dissolving dose. Creams we use anywhere from 50 to 200 milligrams, and you can split the dose. You can split it up to 4 times a day. In the perimenopausal period, we can use 100 milligrams 2 to 4 times a day if necessary. There's for PMS, the last 7 days of the cycle we can use, or days 14. From day 14 on. These are over the counter, 2 to 5%. You can get them at any makeup shop, any drugstore over the counter. You don't need a prescription for these. For vaginal bleeding, if there's estrogen, we're going to stop that. We're going to use 200 milligrams twice a day until there's no bleeding. For endometrial hyperplasia, also 200 milligrams twice a day. You want to make sure that they don't have any anything that's untoward. We have ultrasound in our. We've learned how to do ultrasound now. We have a little mini ultrasound unit that hooks up to my iPad, and so we can do an endometrial swipe quite quickly. It took about 6 months to learn what I was looking at, but it's quite useful, and it kind of keeps us out of trouble. Indications, and this is a little bit controversial. Every woman that's in menopause, irregular menstrual cycles, no menstrual cycles, heavy menstrual cycles, fibrocystic breast disease. Fibrocystic breast disease, we will get the progesterone cream. We'll have the patients use it at bedtime because it is sedating. We'll have them put the cream right on their chest, split the dose in half, and rub it into each breast. Or if there's a cyst on one side, we'll put it all on one side. And usually in 4 to 6 weeks, they'll notice that it'll start to soften up. And endometriosis. Sorry about that. I don't know what happened there. Okay. So this is a summary: progesterone deficiency, agitation, irritability, can't sleep, poor libido, headaches, breast tenderness, swelling, uterine fibroids, excessive menstrual bleeding, and decreased good cholesterol. Just for completeness sake, progesterone excess, worsening hot flashes, increased cortisol, decreased glucose tolerance, increased fat storage, increased appetite and carb cravings, depression, feeling drunk or hungover, just excessively sedated, and water retention. This is a little quiz you can give your patients. We have a bunch of these for all of our hormones. This is the quiz for progesterone. You can use this as part of your intake. You know, 4 is bad, 0 is 0. Any patients over 11 is usually a possibility of a progesterone issue, and anything over 21 is a probable progesterone deficiency. So this is a summary. Pros and cons of progesterone use after hysterectomy. The pros are increased diuresis, triggers catabolic metabolism, relaxes smooth muscle, increases calcium phosphorus excretion, raises basal body temperature, it's sedative and analgesic, improves visual memory, improves proliferation and differentiation of osteoblasts, improves bone density. It's immunosuppressive. It attenuates interleukins 1B, TNF alpha, and NF kappa beta, reduces neuronal loss in traumatic brain injury, regulates the glutamate GABA balance, and improves thyroid function. It reduces all of these under number 13, breast cancer risk, memory loss, slow thoughts, mood changes, impulse aggression, stress, anxiety, suicide ideation, insomnia, emotional flatness, and thromboembolic risk. It's neuroprotective after Alzheimer's disease, and it has a positive association with memory and cognition. The con, the reason not to use it, progesterone secretion induces the onset of a period, lays the foundation for pregnancy, which is of no use after a hysterectomy. And so I asked the students there at AMMG, and I'm going to ask you, so yay or nay, progesterone, yes or no? And with that, we will take questions. And how do I get my thing back? How do I get rid of this now? Hit that. There we go. So there's lots of stuff in the chat. Can
I thank you very much. Your presentation is great. Can I just add something here?
Yeah, I would be upset if you didn't.
Okay.
So go ahead.
I just wanna congratulate you for this presentation because it's very informative. And I just like to add something, especially with the shifting from the axis of the especially after hysterectomy, and we are moving it to HB from HPA or HPJ to HPA, right? From
Right.
secreting estrogen and progesterone to secreting cortisone. And what is the advantage of that in terms of the immune system? Well, the fact is that cortisone, we need it to suppress the inflammation, right? So that's the reason we have it. Most of it, it's just more or less, it's very critical for survival. Otherwise, your body will burn with inflammation. So it helps to dump the inflammation. But the cortisone, when it dumps the inflammation, it dumps it all over across the board. That's mean it dumps all kind of inflammations, including the inflammation, which is the Th1 and cytotoxic T cells, which we needed to kill cancer. So it suppressed the whole forms of inflammation, the Th1, Th17, and Th2 inflammations. While the other side of the aisle, estrogen and progesterone, it more suppress Th17 more than Th1. So what's that mean? That's mean the shift that Dr. She's talking about is to cortisone. It's essential for survival because you need that anti-inflammatory effect. But the anti-inflammatory effect of the cortisone is not balanced. And it suppresses a lot of the cytotoxic T cells and put the patient at risk of having cancer. And the other thing is that cortisone does not stimulate antioxidants as efficient as progesterone and estradiol. So that's very critical too. You need to keep that antioxidant expression to prevent all this aging and all these degenerative diseases and many of those chronic diseases. So estrogen and progesterone are very critical in stimulating antioxidant genes, where you don't see it in the cortisone. So if you remove that, then you will put the patient at high risk of having increasing their blood pressure. They will have diabetes and all that crazy things. So I think the estrogen and progesterone is more healthier than cortisone, and complete shift to cortisone is not something good. It's made good for survival, yes, but it's not healthy. And I think what Dr. William is trying to say here, that it's better if we can maintain the axis of estrogen and progesterone with plant-based estrogen progesterone to maintain the expression of antioxidants and to give us a balanced, healthy anti-inflammatory response where we don't suppress cytotoxic T cells, which is very critical as immune surveillance against emerging of cancer and viral infection. Is that line up with what you're saying, Dr. William, here?
I think so, yeah. Yeah, I think so. You saw there was a whole page there on, I can bring it back up if I can find it here. Are you seeing my screen or no?
Yes.
Okay, so there's a whole page here on all of the different immune regulatory functions of progesterone here. So toll-like receptors 3, 4, 7, and 9, as you all know. I mean, that's pretty much all of them. Interferon beta, it decreases the COX-2 pathway, CD40, 80, TNF alpha, interleukins 8, 10. Remember, interleukin 10 is an anti-inflammatory cytokine. And it decreases interleukin 6, which is an interleukin 1b, which is in almost every inflammatory disease. It helps decrease interferon gamma. It increases apoptosis, it decreases TNF alpha, interferon gamma, interleukins 6 and 12. So it just goes on and on and on. So as you can see, that progesterone has a huge effect on the immune system. So with that, before you go on further, so there was a question here, first question from Beth Teitelbaum on, are you saying do not use supplemental progesterone, testosterone, because the body will regulate itself with other naturopathic remedies? So in my world, no. In Dr. Zarrin's world, I think the answer would be yes. So if Dr. Zarrin, if you're still on, you want to look at that one?
I think your word is correct, because shifting to cortisone axis will not be a replacement for the healthy estrogen and progesterone as expression of antioxidants. Cortisone does not express antioxidants, which you need it to slow the process of aging and decrease the emerging of diseases. So I will completely agree with Dr. William of replacement therapy versus keeping the body naturally shifting to cortisone. It's good for survival, you need it, but it's not a healthy option because you're not going to get the immune balance and antioxidant expression that the progesterone estrogen is doing.
Yeah. So I think one of the
Halarsa, you're right, but at the same time, we need cortisol. So it is the balance that we are looking for. We don't want to underestimate the value of cortisol. It's not just it's the maintenance of a homeostasis, and that's where it is necessary. So yes, as one ages, one has to see that cortisol is not in excess. But at the same time, when you're balancing with the estrogen and progesterone, and the anxiety level, it goes down with the GABA effect of progesterone. And then also the stress will come down and it will also reduce the cortisol level. And so there is a feedback there and homeostasis will be maintained. So I think that the nature's way of healing is reestablished when you supplement with it.
Right. So I'm not saying cortisone is bad. We need the cortisone. I told you it's for survival.
Right.
But we cannot just say,
Not
okay, leave the
survival,
body
but
like this and no estrogen and progesterone, keep the body does it works. No, estrogen, cortisone cannot do the things that estrogen is and progesterone is doing. It will not express the antioxidant. It will not give you a balanced immune response that we need. And I think adding plant-based hormone replacement therapy is critical for post-hysterectomy if you want a healthy body and slow the process of the aging and degenerative diseases. Otherwise, if you keep it like that, trust me, the patient will end up degrading with all the degenerative disease because you don't have that antioxidant expression of genes anymore.
So I think one of the questions is, are the remedies that you use, Dr. Zarrin, do you have the remedies that will either mimic or drive the body to make progesterone on its own?
Yes, it's a question.
Yeah, well, that's my question, because that's one of the things I'm interested in, because I get that all the time.
Absolutely.
I don't want to use hormones. What else can I use? So
Yeah, absolutely. So when we switch from HPG pathway to HPA, as I explained it,
right.
the body gradually, after we remove all the shocks, injuries, grief, and everything, the body gradually is going to shift to the new pathway. And definitely, because there is no ovulations, there is no menstruation, there is no pregnancy, there is no lining of your chest. So the amount is going to be different for the female states after hysterectomy. And adrenal cortex knows how much the female state needs estrogen, progesterone. So that the body does not need any supplementations. I don't know if in the beginning, because during the time, I don't know how long it's going to take for each individual, the body stays in a shock state after removing the female organs. They're giving the hormone supplementation, it can be very detrimental because the body is still in a shock of losing the organs. It's still in a confused state. With giving something, supplementation is just adding more confusion to the system. So definitely the body knows, as I said, explained that the body intelligently would switch over to the new pathways, and gradually after coming from the shock and the shock state, it's going to make enough estrogen progesterone for the female state.
Mm-hmm. Okay. And so one of my other pet projects that, if I get to it before my time on this side of the earth is over, is coming up with acupuncture formulas for the hormonal stimulation also. So what we're doing is matching the symptoms of excess and deficiency for all the hormones to our acupuncture inputs. So I've been working on it for a couple of years. I get to it, I don't get to it. So one day I'll have something definitive. So the next question is testing levels, saliva or blood for estrogen, et cetera. You could also add in urine there, and the answer is yes. Some practitioners swear that only saliva is accurate. Some swear that only urine is accurate. There's some very sophisticated urine tests. Unfortunately, they're quite expensive, but they'll give you a lot of information. My go-to at the moment is still blood tests. And, some practitioners, some of my mentors say that it's not good enough, but we're looked at with a jaundiced eye by the state here, and in the state of Nevada, I have to have blood tests. So like I said, I've been doing this for 20 years. I haven't been here that long, but I'm quite comfortable with the blood test. We'll order saliva tests if we're having issues, regulating things, or sometimes the patients will bring them in, or if they want them. But my go-to primarily is still blood tests. We do saliva tests, and we do urine tests. So there's that question there. I don't know if anybody else has any thoughts on that. I think so. Dr. Gerber here, I know you do a lot of this kind of work also. in perimenopause, is it safe to give progesterone alone since it is a state of estrogen dominance? And the answer is yes. When do you give it? When they have, whether you give it when they have irregular periods? Yes. We would usually do that mid-cycle, days 14 to 25, and also always at bedtime. Dr. Zarrin, from your standpoint, any issues, anything there?
Can you
Estrogen
repeat the
dominance,
question, please?
perimenopausal estrogen dominance. Do you have a remedy sort of protocol?
Absolutely, absolutely. From childhood, puberty, adolescence, pregnancy, lactation, premenopause, menopause, after menopause, hysterectomy, we have answer because we just bring homeostasis, harmony, and balance to the female body by homeopathic medicine. Then female body would decide how much they need estrogen and progesterone. As I mentioned, ratio never changes. It cannot change it. Otherwise, can cause cancer, can cause a lot of problems. But the amount will change according to the female state. So it's perimenopause women definitely needs less amount with the same ratio than the childbearing woman. So then this is not me or any other doctors or practitioners to decide how much the perimenopausal needs, only that individual's body would decide. The only thing that we know how to bring the body into alignment, homeostasis, balance, and harmony, then the rest is the individual wisdom and intelligence to decide.
And I agree, and I think I'm doing the same thing. We're just looking at it from different perspectives. And I think if you take the information from me, take the information from Dr. Zarrin, put them together, I think you pretty much have the best of two worlds. I won't say both, because there's many other sides also.
So Dr. Zarrin, are you against giving hormone replacement therapy for patients with postmenopausal? You don't give hormone replacements. You're doing other way of because that's my question to you. Can you answer that?
Not whatsoever. Hormone replacement is not in our domain. So we do not give anything from outside. We always try to support, stimulate, activate the internal manufacturer in order to produce enough.
But the ovary is completely gone after postmenopausal. There is no estrogen production enough and progesterone enough. So what you would do? I mean, your body cannot replace the need that the women needs. And one of the reasons that guys, they have high risk of hypertension versus women during the time below 60 years old, before menopause, is because that they have this estrogen protection. It's expressed antioxidant. It gives you that muscle relaxant and a lot of good things that estrogen has, giving protection for the women's. So how are you going to replace that? Because if they are the postmenopausal, the manufacturer is not there anymore, and your adrenal gland will not produce enough of estrogen and progesterone that the women need to be protected. I know you're doing detox, you're opening up their receptors, you may have some stimulation of the adrenal producing some of estrogen, but is that enough? That's my question.
Dr. Halissa, based on what data and information that you say the estrogen that is produced by adrenal gland is not enough? Based on what data are you talking about?
I will send you many data, because that's what, okay. I mean, if you can treat postmenopausal and you can balance and you can produce and you can show that estrogen progesterone is produced in an optimal level that will keep the patient from osteoporosis, that's a big thing, because we are challenged by postmenopausal osteoporosis and increase their blood pressure and stroke and everything. I mean, that would be good if you can do it without adding hormone replacement therapy. So I would like to hear from you. Where is evidence from our side? We know that postmenopausal syndrome, and we that's what the thing that we're doing is just giving them what they are missing, because we feel that the manufacturer that they used to be producing it is not there anymore. Well, but I can share with you all that. But if you can produce enough of estrogen and balance estrogen and progesterone from the adrenal gland as it was before an ovary, that's a big jump. That's will save take a lot of money, business from Dr. William.
That's
all right. Don't worry about it.
I do. Dr. Halassa, not only I don't give supplements or hormones. I take them off. I just get them off. I have a postmenopausal women that they have been on, hormones for years. I get them off because I just do whatever I explained that in my talk to shift the pathways. And then when I'm sure that the body is shifted, so then that's enough. I get them off. Hundreds and hundreds of people have been off after my treatments. So there is not me, you, and anybody to decide that how much the estrogen, progesterone the female needs. Their body decides, as long as the harmony and homeostasis is back. As I said, nature never let human being down. Always have a survival backup for human beings. So one of them is the HPA pathway. If HPG is gone, is destroyed. But it's quite a work. It's quite a lot of work, a hard work to do so. But people who are coming to me, they're willing to be patient and go through it instead of going on, those supplementations or hormone therapy. So this is absolutely what you call it, successful in terms of hormonal treatment after menopausal. So I have a lot of actual proof. So the human body decides on its own and just activate it and give actually support, give whatever it needs. That's why nutrition is a big deal. Nutrition is a big deal. The very first thing I do with the patients, just completely switch them over to the right nutrition, especially the genetic diet, according to the blood typing. And by the way, Dr. Alas, I think you mentioned, I don't know if your question was related to my talk, it's related to Dr. Clearfield talk about.
Well, let me add something that is critical. Maybe this will create some balance between both sides of the aisle, because I like to create that balance. Okay, we have problem, yes, of doctors. They are having those patients who are postmenopausal, and they immediately give them high dose of hormonal replacement therapy without detoxing their body and without opening up their receptors. And that's the dumbest way of doing things. And then you would have all these toxins, accumulation of estrogen and progesterone metabolism, and you would have problem there. Okay, so excessive replacement and lack of detoxing the body and opening up the receptor of estrogen progesterone is one of the abuse of hormone replacement therapy. What we need to do before we do hormone replacement therapy, we need to detox the body, and we need to give them all the supplements, the polyphenols and things that you're doing to open up the receptors. And then we do the hormone replacement therapy. And so the hormone replacement therapy needed is going to be so less than if you don't detox the body. So that is, yes, that is justification. But saying that with just detoxification, opening up the receptors and depending on adrenal gland to completely replace the need of estrogen progesterone, I may disagree with you. Even the reason why, because as I said, men and women's have less risk of having hypertension than men before age of 60. And the reason, because the estrogen that's being produced by ovary, which we don't have as men, is giving them that protection. Okay, so still it's more healthy, it's more good to add some plant-based estrogen and progesterone, but after detoxification of body, then I think we are here in a balanced, and that maybe both I will agree on that, in a state of completely saying no and depend on adrenal gland producing enough of progesterone and estrogen, because I don't see that reality from my side yet. So unless you have some evidence that shows that what you're doing is making enough of estrogen progesterone out of adrenal gland, then we can talk, because that will be also good for not just for the female, but also for the male side.
So Dr. Alasa, you just compare, just simple comparison between a woman that is going through monthly cycle, have ovulations, and have always menstruation, and goes through pregnancies and all that, compared to postmenopausal woman, compared to how much hormone that woman compared to that woman needs. So why, based on what data you say that adrenal cortex cannot make enough hormone for that woman?
Well, I'm just,
That
I did compare between male and female, and I told you that females, they have less hypertension risk than male below the age of 60 because of the estrogen and progesterone protection. They increase the expression of antioxidant, they cause vasodilation. So that's the reason. So I'm talking about male and female. Now, talking about premenopausal and postmenopausal, again, the drop in the estrogen and progesterone after postmenopausal, it's actually speeding the whole process of degenerative diseases and autoimmune diseases and all things, because those progesterone and estrogen that ovaries produce is not just for maintaining the female organic system, but also it is very important in expressing antioxidant all over the body and slow the progression and degeneration process of all the diseases. So those patients who are postmenopausal, they don't take any hormone replacement therapy. I'm talking about plant-based, and after detox, not before the detox, most of the time they age faster. They end up with all the diseases and all that thing. Now, if you said to me that, well, adrenal gland will give that woman enough of progesterone and estrogen that will maintain and prevent the speeding of the aging, I need that proof from your side to show that the liver estrogen and progesterone is enough. Because you know, me and Dr. William, we can agree on that the estrogen progesterone needs to be maintained not at what is equivalent of their age, but it will be better to be maintained as they are young. So if you can come up and say, I can produce enough estrogen progesterone of a patient who are 70 years old, the same amount that she is in 30 years old, that will be a great thing. And there's no harm in the estrogen progesterone. Estrogen progesterone, it increased the expression of antioxidant and keeping the level same as it was at the age of 30 for the female at 70, regardless of the reproductive system. We're not talking about their function there. We're talking about the estrogen and progesterone as a stimulation for antioxidant genetic expression and slowing the aging process and all the degenerative diseases. So that's from our perspective, me and Dr. William, that's how we see the hormone replacement therapy. But I think your perspective is that you're having some studies and tools that you can produce enough of estrogen and progesterone for the female that will prevent osteoporosis and slow the aging. I like to know those ingredients, and I want to know how much of estrogen and progesterone is being produced by adrenal gland. Do you have that study? Do you have their levels? And do you have females that they don't have osteoporosis and they're doing that? Will be a great, then we don't need to give all this things that we're doing. So that would be great, but we need to have that evidence going and showing the mechanism and how much you're producing and show me the lab results that you have.
We don't have lab. Homeopaths don't work with lab. Homeopath will give whatever is necessary needed to each individual, and the lab is inside that individual. I'm not inside the human body to measure things for you. So, but we have actual proof. One of them is sitting here. I'm the actual proof. So, and I have many actual proof that they came to me with high level osteoporosis. They have been on hormones for years. I took them off for months. I took them off gradually, and I put them on my system of medicine. And after less than a year, they went for the blood test, and there is no osteoporosis detected. So these are something that you have to ask the patients who have been cured. So we don't have that kind of information that you have. We don't work with labs. So we are coming from two different worlds, you know, you and Dr.
Yeah, so that's what we're trying to present. Let me finish a couple of these other questions. It's getting kind of late, you know, back where you are. So in perimenopause, is it safe to give progesterone alone since it is a state of estrogen dominance? The answer is yes. Usually we'll give it nights 14, always at night, nights 14 to 25, 1 to 200 milligrams is our sort of our standard dose. If you need it in between, those are FDA approved. You know, you can go to any pharmacy and get that. If you need in between doses, then we have to compound it. When do you time your testing? Again, days 19 through 21. Can you use progesterone alone in PCOS since it is estrogen dominant? The answer is yes, you can use it alone, but you will probably find some testosterone excess. So we're going to want to address that. And there's some nutritional issues that develop from PCOS also. So we're going to want to address that. Do you give progesterone to a PR positive breast cancer patient since it's breast cancer protective? The answer to that is yes. When do you prefer using a cream over an oral? The oral progesterone is much more potent than the transdermal. And so if we're really estrogen dominant, if we're having symptoms that are not controlled with the cream, we'll go with the oral agent. And some patients don't like the creams. Can we treat hot flashes by using progesterone alone? Usually not. I mean, you can get some improvement with it, but you can actually treat progesterone or hot flashes with testosterone alone and without estrogen. And usually just a little bit of testosterone, like a 0.5 milligram a day for probably about anywhere from 1 to 3 months. Do you treat patients just by using progesterone without estrogen, especially in the history of breast cancer, with a history of breast cancer? And the answer is, we have plenty of studies that show that the patients actually do better on natural estrogens versus no estrogen, especially with survival rate. The survival rate 10 years post estrogen, post breast cancer on patients with no estrogen is about 67%. The 10-year survival rate with natural estrogen, natural progesterone, and natural testosterone is 94%. And if you need the reference for that, I can get it to you. After TBI, what dose do you and frequency do you use? We usually, I mean, if the patients are hospitalized, we want to use intravenous progesterone 8 milligrams per kilogram, and we'll use it continuously for 48 hours. Usually, if a patient is as an outpatient, we'll use a progesterone cream, and we'll use a 5% cream. We'll have them use it 4 times a day. And yes, we'll use it for men for about 5 days also. What's the normal value of estrogen progesterone ratio? Less than 250. And do you monitor hormones via blood? I do, and we also use saliva and urine, but my main go-to is blood. And some of my mentors and colleagues would disagree. And this next one I don't know the answer to. Is there an optimal percent of body fat to the estrogen effect of adipose tissues enough to sustain all the positive benefits of estrogen? I don't know the answer to that one. I don't know if Dr. Zarrin or anybody else. And those are all the questions in the chat. Anybody have any, Dr. Gerber, I don't know if you're still on, you may know the answer to that, or anybody else. Any questions, any comments? If you like this sort of format, you know, we would certainly, you know, be happy to continue. If there are topics that you like, we would certainly address them. We are proposing this to be as a fee. We haven't quite come up with that yet, and I think what we'll probably do is use a different channel than our regular one, so to sort of filter out, you know, the.
Well, just Dr. Patel,
Right.
what blood level of estrogen you are shooting for approximately?
Again, I actually don't look at an individual blood level. For estrone, I want it to be under 100. But what we're looking for is the estrogen progesterone ratios. And the ratio that I want is less than 250. We take the estradiol plus the estrone divided by the progesterone. That's how you find it. Less than 250 is our goal. It's irrelevant to me what the blood levels, what each individual level is. It could have a little bit, you could have a lot. It really doesn't matter.
So you order the estrone and estradiol both?
Yes, estrone, estradiol, progesterone, and testosterone. And we get a sex hormone binding globulin and a free testosterone also. Okay.
Thank you.
Okay. Anybody else? Any questions, comments? We're on Zoom, so you can't throw tomatoes at me. So virtual tomatoes.
Eggs.
And so, you know, what we wanted to show you that there's two very different worlds and we can bring them together. Okay. And we can argue about them. But, you know, what I learned from Dr. Zarrin is now I'm going to go look at all of the remedies that she brought up, and I'm going to find the ones that I can incorporate from what I do.
Absolutely.
Well, how about the ingredients of Dr. Zarrin will contain plant-based estrogen and progesterone? How about that? You may end up finding it's actually already giving them a plant-based estrogen and progesterone replacement in your ingredients. So let's find out exactly what you're giving them. I am very curious. Dr. William, can you find out? See if he may already.
I will stay on it.
Okay, sound great.
Okay, everybody.
I don't give even plant-based hormones, so I just give them food to make.
I think he's using that as a sort of a catch-all term for your remedies. So
Plant. Okay, homeopathy is not plant-based, so homeopathy is absolutely a different system of medicine.
Right. All right, we will come up with that answer for you, Dr. Halassa.
Yes, I think Dr. Halassa should take the course. Should be the first one to take the course.
I will be the judge between both of you. That's what I'm doing here.
And just to let you know,
Dr. William getting along, Dr. Halassa, me and Dr. Clear will be getting along so well.
We get
but you're in the middle.
We get along. You're the referee.
You're the judge. But
no, I'm the judge
that votes for Dr. Clifford more than for me.
I'm also the counselor. I mean, I'll be consulting both of you and come up if you disagree or something. I'll put you together and we calm down and we can have that talk to agree or disagree. So I'll make things work between you both of them. If things got worse, you know.
We've been working well. We've been working well so far. We don't need your help. We get along fine.
You know, the course is normally for practitioners that it resonates with them, that they want to have another natural modality added to their current practice or something, and they're looking for something to expand their practice or something. It's not for argument or it's not for, approval or disapproval. It's not for that. No judgment, no prejudice here. So I'm a homeopath, you guys are osteopath, medical doctors. We're coming from different worlds, but this course is only for people that they are open-minded and they really want to kind of, expand their practice.
But if you want a little bit more closed-minded course, Dr. Halassa, I have a 7-video, 10-hour introduction to bioidentical hormones, which is CME approved by the AMA and the AOA for 10 CME credits. It's a video course, and it has a workbook. It has check-off sheets. It has clinic notes that you can use, so you can get that if you want. So thank everybody for staying around.
Let me add something here. My grandmom, okay, she died at the age of 100 and she never take hormone replacement therapy. So maybe she will be agreeing with Dr. Zarrin. She say, yes, she's right, you're wrong.
That's me. I never ever took one pills of hormones in my life, and I'm old enough to say that I'm actual proof. So that we don't need no osteoporosis, no immune problem with immunity, no blood pressure, no weight gain, nothing. I have nothing. I must say, because
But
I do it
she's
correctly. I do it
What,
correctly.
but the organic food that you're eating and the things that you're eating, it will contain some sort of plant-based estrogen and estrogen progesterone. Just we will go to the ingredients because when my grandmom she's eating, she's everything organic, everything from the nature. She lives in the mountain, and those plants they are rich of estrogen and progesterone.
Eat them as food. As I said, eat them as food. I eat
Yeah,
them
but those food
like
that you're eating, those food that are eating, you will see because what we're talking about plant-based estrogen and progesterone, it's actually the organic food that we're eating. That's how they extract them.
Dr.
So
Halasa,
that's what we're gonna do.
progesterone.
We're gonna see your ingredients, and trust me, you will see they contain estrogen and progesterone because the food that we're eating they contain those ingredients.
Okay,
Just they
Dr. Halasa, there
concentrate
is
them.
no such a thing. Estrogen, progesterone is not like estrogen, progesterone in nature, in food.
No, it
There
is.
are some ingredients that the body makes estrogen, progesterone out of them. The way that makes it out of food and out of everything. So I don't know what you say.
I'm talking about plant-based estrogen and progesterone are extracted from plants. They are plants. They are not synthetic. They are plants. So if you eat organic foods and you eat healthy foods and all that, especially the greens, the greens contain estrogen and progesterone. So I hope you understand that those are not synthetic estrogen and progesterone. Those are plant extracted. It's like curcumin. They're extracting it from the plant of curcumin, right? So it's an extraction, but trust me, I 100%, and Dr. William will go through your ingredients and he will find estrogen and progesterone because it is extracted from the plant.
How did
They're
I
not
get
synthetic.
this? Okay.
Before we get into fights.
All right. And with that, I think it's time to say goodnight.
Yeah, I think it's time.
I want to thank everybody who's been here. So we have a couple of my patients are here, Candy Levin and Darla Wilson, and we had a couple of early ones earlier on. Dr. Burgess, Dr. Cruz, thank you again. Dr. Centric for being here. Dr. Nario, Dr. Patel, Dr. Zarrin, thank you so much. Marie, thank you for being here as always. Steve, thank you for being here. Joel, also. Next week we have Mikhail Berman, who is a physician in South Florida. He's written several books, again on natural medicine and some hormone replacement. He's from the USSR originally, so he has a perspective of Russian medical literature. So I think he'll be quite interesting. With that, we're going to have Dr. Zarrin and Dr. Halasa go to their respective corners, and maybe we'll have a,
We love you, Dr. Halasa. We love you.
Of course.
No worries.
Of course. Okay. Thank you, everybody, for being here. And thank you so much for sticking with us. I mean, it's 7:15, so our time anyway. So thank you all. We'll be here next week, same time, same station, and we'll pick it up again. Anybody have any questions, comments? Otherwise, good night.
Dr. Burgess, bye. Bye, everyone.
Bye.
Dr.
Hey,
Bye,
by the way, I'm gonna say
Bye,
that
Dr. Philip.
my job is to steal the thunder from Dr. Halasa, Dr. Zarrin, and Bill. So that's my job, to steal all of your thunders.
Well, please do.
Thank you.
Take care. Thank you so much, everyone. Thank you. I
Thank
appreciate it.
you.
Bye-bye. Bye-bye.
Okay.
Dr. Burgess, I sent you something in your messenger, Facebook. Did you see it? The prank?
No. Oh,
Watch that prank. The guy there, he sounds the same, your voice, your unique voice, and the way he communicates, way he talks, it's the same. So that's why I sent it to you. Just watch it, you and your wife, and you just laugh.
yeah.
He sounds like you exactly.
Keep me informed.
I just sent it to you. It's in your Facebook messenger.
Thank you much. Thank you,
All right,
guys.
take care. Okay, bye.
Bye.
Okay.